Thank you, chairpersons, for the kind introduction. I am presently posted at the base hospital in the Delhi city of Delhi. This hospital is affiliated to this medical college, which basically has undergraduate teaching as of now. Will soon be having postgraduate teaching. Uh, this hospital is a 1,000-bedded hospital, a tertiary care institution in Delhi. And if you compare it to AIIMS in Safdarjung, that's how base hospital and the army hospital are the better known army hospital in Delhi would figure. For the last 1.5 years, we've been designated COVID hospital. So we've been battling COVID. And I thank the organizers for giving me this opportunity and sort of refreshing my knowledge on endocrinology, because I've been busy with COVID last 1.5 years. The topic that's given to me is actually what the chairperson would have loved to speak on. It's on imaging in pheochromocytoma, something which we often reach after the clinical diagnosis and biochemical confirmation. But it's something that's very important because there's one situation where imaging has so much information to offer, and we're often actually stuck with so many options that most of the things that we don't understand. So in the next few slides, I'm just trying to go through the way we go about approaching imaging of pheochromocytoma. We all understand it's a rare disease, thankfully. These are tumors which basically arise from neural tissue, predominantly from the adrenal medulla, but quite a few of them actually come from extra medullary tissue, which is what is called the paragangliomas. Earlier known to be about 10%, but now we know that the extra adrenal tumors are far more frequent than what we know. The 10% rule that we all read in college was actually something which was a gross underestimation. Now we understand that the genetic predisposition is far higher. And as we know more of genetic disorders, we'll probably see that this percentage will continue to rise. A lot of these tumors metastasize, and they are far more than 10%. And now we see that these paragangliomas are much more frequent, especially in the younger patients. Unlike other disorders in endocrinology, where probably if you do not diagnose them on time, or you make an error, like something similar to primary aldosteronism that the speaker spoke, we would probably have a patient who's poorly controlled for a few more years. But here is a situation where if you do not diagnose on time, it could be fatal. And that's something which makes proper diagnosis on time so important. Often these tumors are silent, and even then it becomes very important to diagnose them, because handling of these tissues, not knowing that they are from the adrenal medulla, can be actually fatal. And of course, often in clinical practice, we get adrenal masses which need to be more often excluded that they are not adrenal medullary tumors than confirming that they are. So how I would go about this presentation is talk about where does imaging come in the management plan of adrenal tumor or a paraganglioma. Initially, it is the structural followed by the functional imaging. A more practical approach to it, because as the chairperson just spoke, a lot of things that are mentioned in the textbooks and journals are actually not available in the country right now, especially the nuclear imaging modalities. So like in all endocrine tumors, the role of imaging is only once we have confirmed the diagnosis, which requires clinical as well as biochemical evaluation, which is very important, because there are so often that you would find incidental tumors in most of these glands that confirmation is very important. But in incidentally detected adrenal masses, to rule out pheochromocytoma is equally important. And after having excluded, you would actually have to be 100% sure. So you need to actually go ahead and do further imaging than what has already been done, in which this incidental tumor was picked up. And of course, in patients who have genetic susceptibility or who've had tumors who've been treated and have risk of metastasis and are being followed up, in them, screening and surveillance is one more aspect where imaging plays a major role. So when you classify the imaging modalities in adrenal tumors, especially pheochromocytomas or paragangliomas, the initial ones are the morphological, followed by the functional, and then of course a combination of them, which helps better than just a pure functional imaging. The morphological imaging, as the term is self-explanatory, is to locate the tumor and look at the structure. Usually these tumors can be less than 1 centimeter to beyond 15 centimeters and pretty large, but average of around 4 to 5 centimeters is what they are at the time of diagnosis. They're often small, and at the smaller stage, they are usually solid and relatively homogeneous. But as they grow, they tend to have a central necrosis. They sometimes can be cystic lesions. They are usually benign, so you would find a round spherical structure with smooth edges. But because of the vascularity, they often can be difficult to differentiate from adrenal metastases or adrenal malignancies. Ultrasound is not the way we normally diagnose pheochromocytoma, but these are tumors which can be picked up on ultrasound as an incidental mass. And if it's a large enough tumor, it can be picked up on ultrasound, and what one would see is a vascular tumor, maybe have some central necrosis and some calcification, which may lead you to a suspicion that in a clinically relevant setting, that this could be an adrenal medullary tumor. But what is more important as far as structural imaging is concerned is CT scans, and contrast CT scans are the classical way in which one would approach diagnosis of adrenal medullary tumors. These are widely available investigation modalities. They're relatively less expensive, and the resolution is much better, especially with contrast. For tumors which are above 5 millimeters, the sensitivity is pretty high in picking up these tumors. And unlike the adenomas, which are fat-rich, the Hounsfield units are usually less than 10, but in pheochromocytomas, this will be mostly about 10. So anything less than 10 generally rules out adrenal medullary tumor. And often after contrast, the enhancement is pretty high. More than 110 times you would find these tumors enhancing. But in patients, in certain tumors, especially metastases, adrenal carcinomas, and pheochromocytomas, you may find some amount of lipid tissues, especially when there is degeneration. So this may confuse in certain settings. So if you look at the normal CT scan, the adrenal gland is fairly difficult to find. And for a non-radiologist, it may be actually quite difficult actually to locate. So these are the arrows which point at that. So often, if you are able to see the adrenal glands properly as a non-radiologist, you may presume that there is something wrong there. That's how I look at it. But as contrast is given, these tumors, which are usually more than 10 Hounsfield units, they enhance well. And there is a concept of washout, which is, there are two values there, the absolute washout and the relative washout. The formula is mentioned here. Now, these are the way of assessing whether this tumor has any tendency of being benign or malignant. Now, these are fairly overlapping when it comes to assessing pheochromocytomas or adrenal malignancies. So although if the washout is good, it usually favors a benign, but one cannot be pretty sure if the washout is not so good. So when we do a CT scan, a relatively homogeneous mass in a smaller solid lesion, but as it grows, you may find some cystic changes. You may find some calcifications. And of course, I mentioned about the washout aspect. But most of these factors have to be taken into consideration in the clinical setting that we are looking at. So looking at some of the scans of these tumors, if you look at this lesion, without contrast, which enhances on contrast from 37 to 91 Hounsfield units. This is a feature of any benign mass which can enhance, and so would a malignant mass. But a large tumor like this would have enhancement more in the peripheral tissues with some cystic changes within it. Now, this is the scans which show the washout, the non-contrast enhancing on contrast, and then there's been a washout. CT scans are pretty okay in most of the clinical settings, and most often you would not require to do anything else if the patient has classical features of pheochromocytoma, which has been confirmed biochemically. MRIs are usually not better than CT scan as far as this aspect of radiology is concerned. The spatial resolution is not better than CT scan. They are less available and more expensive. The time of scan is much more than a CT scan. And of course, the problems associated with some implants that can happen. So MRI has its own problems. But yes, in certain situations, like in pregnancy, where you do not want to radiate excessively, or in patients who have some reactions to contrast agents, MRIs have a role there. The features on MRI of pheochromocytomas, when we compare T1 and T2 images, I'll show you some images there. The T1 images are hypointense and becoming hyperintense on T2, which is seen both in the axial and the coronal sections. And something similar happens like when you give contrast in CT scan. When we use gadolinium, the enhancement is quite similar. But like you have the washout in CT scans, you have something called in-phase and out-of-phase images in MRI, and where it is seen that in tumors which are lipid-rich, which would pertain to adenomas, you would find that there is the hypointensity is far more in the out-of-phase images compared to an in-phase image, whereas that would not happen in a tumor which is lipid deficient, which is usually true for pheochromocytomas. So this is one way where MRIs would be able to differentiate between adrenal adenoma and a pheochromocytoma. Contrast enhancement is pretty similar, where you would find that gadolinium would enhance a tumor much more. But structural imaging has its own problems. In any tumor which is functional, although the structural imaging gives a lot of sensitivity, as far as the specificity is concerned, has to come from a functional imaging. And that's why there is a role in adrenal tumors or paragangliomas for functional imaging. And often to confirm, following the structural diagnosis, you would have to do a functional imaging. The other advantage, of course, is that in a functional imaging, you can do the whole body scans, which would look at extra-adrenal tumors, metastases, and of course, when we are looking for recurrent disease post-therapy, it has a very good role. Often like we discussed, the blurring of differentiation between malignant adrenal masses, which or the cortical masses and the adrenal medulla, the differentiation may be quite difficult with just a CT scan or MRI, and that's where there is a role for doing functional imaging. So in situations where clinically you can expect that there is likelihood of extra adrenal involvement or metastasis, and these are situations where the individual is young at diagnosis, there is family history, there's a history of recurrence after surgery, and of course a patient who comes with multiple tumors, or there's a syndromic presentation like MEN or VHL, or a tumor which is large to begin with at diagnosis, and biochemical phenotype of noradrenaline and dopamine excess. Now, these are tumors which are more likely to have metastasis even to begin with. And so here, functional imaging to start with, of course, has a better role because you can pick up lesions outside the adrenal glands. The classical functional imaging that we've all read from beginning and which is was always used and still continues to be used is the MIBG scan. Although 123 iodine is what is mentioned classically for this diagnostic part, and 131 iodine for the therapeutic part, but 123 iodine is difficult to find in practice availability wise, and often in low dose 131 iodine is used for diagnosis and a higher dose used for therapy. Structurally, it has similarity, and that's how this molecule finds itself into the cells in the adrenal medulla, catecholamine generating cells, and that's how you are able to functionally pick up these hotspots. Now, this pickup is there in adrenal medulla as well as the ectopic adrenal tissues or metastasis or recurrence happening elsewhere. And hence, it's a diagnostic modality of choice when you're actually looking at metastatic tumors. It also helps us pick up tumors which are likely to take up 131 iodine MIBG when you're going to use it for therapy after diagnosis. The specificity, like I mentioned, is pretty high for them, but sensitivity remains at times wanting, especially in paragangliomas and metastatic tumors and recurrent diseases. These are tumors which may functionally have got degenerated, may not be so active functionally, and hence you may find that the uptake is not so good. But if there is uptake, their specificity is pretty high, and that's what makes MIBG an important functional modality. The next update that came as far as the functional modality for localizing tumors came was the somatostatin receptors, scintigraphy. Now, these are receptors which are, like we all know, from numbered from 1 to 5. Classically, you would find that 2 and 5, which are more commonly present, but most of these receptors are present in these tumors. And so these somatostatin analogs, which are radio-labeled, have a tendency to home on to these tissues, and so it makes it even more specific. The first somatostatin receptor analog which was used was the pentatreotide, or what we know as Octreoscan. Again, availability-wise, it's not something which is easily available. This was something which came after MIBG. It has better sensitivity in picking up head and neck tumors and metastatic paragangliomas compared to MIBG. And since the emission is gamma, you can only use a SPECT method for visualizing them, and compared to PET, it always remains inferior as far as spatial resolution or localization is concerned. So what happened next was actually a far better improvement, which was PET. Which came thereafter, and that is what has taken over most of these imaging modalities now. And of course, even the analogs, which are somatostatin receptor analogs, have now improved to what we know as DOTA-TATE, DOTA-NOC, and DOTA-TOC. These are three of most common ones, DOTA-TATE being the commonest and the most often used in clinical practice. Now, they have the radio label is the 68 gallium. It tends to go and bind these tissues, and the specificity is pretty high. To the extent that it's even superior to the FDG and FDOPA PET, which are known to have far higher specificity. The sensitivity, at least. Specificity wise, there is an issue when you compare. I'll come to that in the next slides. So if you compare DOTA scans, which are 68 gallium labeled, to the Octreoscan, which was there earlier, you would find that there are these are scans from the same patient which show that the number of metastases that have been picked up are far, which is quite obvious that the pentatreotide actually missed all of these. So these are the ones which are used in practice now. The commonest being the DOTA-TATE, which has the specificity for receptor number 2 and 5, which are ideally suited because these are the receptors which are typically present in these tumors. As far as genetic analysis is concerned, to see what kind of tumors are there, the studies show that it's not required. They are fairly broad spectrum. And when you use these modalities, you're actually able to pick up most of the paraganglioma specifically. So these are a few case studies from the references that I have quoted later, that where on a structural imaging on CT scan, when you pick up these tumors in the adrenal, the DOTA-NOC PET actually shows increased uptake. The uptake is poor in the areas which are shown as cystic and more in the peripheral rim of the tumor. And when you combine PET and CT, that actually gives you the advantages of both structural and functional imaging, and you show these hotspots, which gives you a confirmatory diagnosis. Now, this is a patient who has come back after surgery, who's already undergone a right adrenalectomy, has come back and during follow-up has shown a raised metanephrin, which suggests recurrence. And here on MIBG scan, there's a hotspot, which is now has again been treated with the I-131. Now, this lady, when she comes back for follow-up at 5 years after that therapy, you do a FDG PET and you find that there are hardly any spots. You're pretty happy. But the same patient undergoes a gallium dotatate scan and has these other spots that picked up. So although FDG is fairly sensitive in picking up quite a few areas where there is increased metabolic activity, it's not as specific as a dotatate scan. And you'll often find that there are certain areas where FDG was not picking up, has now been shown to be picked up. So the sensitivity and specificity is both higher with these scans. And that's what makes them the modalities of choice at this time. FDG PET does have its role, especially once the diagnosis is known and is on follow-up. These are patients who can actually undergo FDG scans, because you know that whatever hotspot they are showing is likely to be recurrence. And as compared to MIBG scan, they are definitely far better. There is a difference as far as the underlying genetic mutation is concerned. When you use whether you use FDG or FDOPA, although FDOPA is not so easily available in the country, FDG is what is often used by the nuclear physicians. But the detection rate with FDG is higher in patients who are positive for SDHD mutation. DOPA is more specific as compared to FDG, obviously because of the nature of the marker that's used. And especially for head and neck paragangliomas, it's an excellent diagnostic tool. This is where the MIBG is lacking. And structurally, even CT scan would be a poorer modality here. One would have to do an MRI, followed by functional, if one can use DOPA. Otherwise, one would have to do a dotatate scan or a FDG or a DOPA PET, depending on what's available. This is the case study which shows the superiority of dotatate scan over FDG or FDOPA. And you find that in the same patient, the number of spots which are picked up by dotatate are far higher than FDG or FDOPA. And of course, this being a SDHB mutation where FDOPA is not, it's in fact inferior to FDG. That's why you find FDG is picked up more lesions than DOTA. But DOTA remains superior to both these modalities. So to summarize the functional imaging aspect, as far as sporadic pheos are concerned, which are restricted to adrenal glands, MIBG remains superior. And in fact, it's easy to do, and most availability wise, it's very good. But in head and neck and retroperitoneal paragangliomas, you would find that the FDG PET is a modality which is better than MIBG. DOPA is more specific than FDG PET, but availability wise, there's an issue there. As far as the metastatic pheochromocytomas and paragangliomas are concerned, again, FDG PET is preferred, but with now availability of the somatostatin receptor analogs, I think that becomes better than these modalities. And of course, the advantage of as far as therapy is concerned in these situations, earlier 131 MIBG was what was being used. Now we also have 177 lutetium and yttrium labeled somatostatin analogs which can be used. So that's something which will again take over from 131 MIBG. The problem happens with paragangliomas, which are biochemically negative. These are tumors, especially in the above the diaphragm. They are in the skull base or in the neck. They may not be functional. So functional modalities actually may fail to pick up. So often these are picked up by either FDG PET purely because there is increased biochemical activity, metabolic activity, or they are just picked up by MRIs. So these often may not land up with endocrinologists, so probably we may not have to worry about it. So to just summarize my talk in the next 2 slides, as far as the structural imaging is concerned, ultrasound is not so important. It just picks up incidental tumors, but most important is CT scan. And we only need to start working up for these tumors as adrenal medullary tumors if the Hounsfield units are more than 10. And they are enhancing very well with contrast, and the sensitivity is pretty high to pick them up. MRI is only required in certain situations where CT scan cannot be done, or in skull base and neck tumors where they tend to fare better than CT scans. As far as functional imaging is concerned, MIBG remains an important modality and widely available, and it's relatively low cost, and specificity wise is pretty high, although the sensitivity may suffer at times. PET-CT remains the modality of choice. Now, what labels you use depends on availability and the kind of tumors that you're dealing with. If available, then DOTA remains the most sensitive and specific way of localizing these tumors. But FDG PET has its role in situations where you are looking at tumors which are not biochemically active, or for dedifferentiated tumors where you may not have these somatostatin receptors present. And that's where FDG PET actually may have a better role than a somatostatin receptor based modality. So to conclude, like in all endocrine tumors, biochemical confirmation is the initial step. And that's most important. That's, I think, in every aspect, we must actually ingrain this into our students as well. Followed by structural imaging, where contrast CT in most cases, MRI in certain selective cases, and of course, functional imaging, which has greater specificity, and of course, it has the power to detect multiple tumors, metastasis, and recurrence. MIBG remains important. The next step would be PET scan, depending on what markers are available. And choice of imaging modality in most clinical decision making has to be an individualized approach. And we as clinicians need to balance availability, affordability, and of course the accuracy of diagnosis. That would be the most important thing. Thank you very much. These are my references, few of the recent ones that I picked up. In fact, the endocrine guidelines are almost 7 years old now. And 2 of my colleagues that I wish to pay my gratitude to from the Department of Nuclear Medicine and the Department of Radiology.